Okay, we'll give it one last minute. We'll see if we have a few more tricklers. Huh? No, no, we don't want people, but I think people like were still, I know, wrapping up lunch. The first session. Oh, okay, that too. And Home just highlighted that some of them thought it's 1:15 instead of 1:10. So, yeah. Okay, it is 1:10, so we will get started. Good afternoon, everyone, and thanks to all of you who made it on time, ahead of time. Yeah, and I see some people coming in. Please welcome, come in. Um, I hope you all had a good lunch, and I hope you've had your coffee and feeling awake and bright for this session. So this afternoon, we have a session on community deaths under the theme "Who Dies of What?" So I do understand there are two other parallel sessions, one on MCCDs and the other on ICD and coding technology. But as you'll hear soon and shortly from all three speakers, we all know that community deaths and how cost of death is determined for those is of immense value, especially in the countries and contexts we work in. So we have three excellent speakers here today who are coming from three different countries, Vietnam, Kenya, and Ghana. I will introduce them and we will do, each speaker will present for about 10 minutes. And if we have time, we will do about 5 minutes of Q&A right after each speaker. And then that will still leave us 20 to 30 minutes at the end to do like a panel. And so if you do have questions, please write them down. And I do know we have some participants who've joined us online. So even to them, if you could just provide us your name, your organization, and the question you have, we will read them out at the end during the speakers panel and we will address them. And if you have it addressed to a specific speaker, please do mention that as well. So yeah, so introducing the three speakers for today. So first we have Cho Hong. Cho is a public health and population specialist with more than 20 years of experience as a researcher, project manager, technical expert, and program coordinator across a wide range of public health initiatives. His work has focused on population and demography, reproductive health, HIV/AIDS, health system strengthening, quality improvement, and CRVS. He currently serves as a country coordinator at Vital Strategies, a role he has held for more than 3 years supporting Vietnam's CRVS improvement program. In this capacity, Cho works in close partnership with the Ministry of Justice, Ministry of Health, and National Statistics Office to strengthen the civil registration system, improving data interoperability and cause of death reporting. Cho holds a bachelor degree in population demography and a master's degree in international health. Cho, if you want to wave to our audience, yeah, that's Cho. Our second speaker for today is Jane Moria. Jane is a country manager with the CRVS program at Vital Strategies again, with many years of experience in research and public health system strengthening. Her current interests in research are in mortality and cause of death, digital public infrastructure, including CRVS ID systems, digital transformation, and gender equity in CRVS. That's Jane, right in the middle. And last but not the least, we have David Adambire. He's a postdoctoral research fellow with the Sustaining the African Health Initiative Community of Practice project at the Regional Institute of Population Studies, University of Ghana. He was a Banga Africa Project Scholar. He holds a PhD and a Master's of Art in Population Studies from the University of Ghana and a Bachelor of Arts in Integrated Development Studies from the University of Development Studies, Tamale, Ghana. He has over a decade of experience in research coordination, data management, and advanced statistical analysis. His research interests lie in population health, gender, and adolescent reproductive health. So thank you to all three speakers for being here, and over to Cho for his first presentation on improving community causes of death in Vietnam, a proof of concept. Thank you, Cho.
Okay, thank you, Mira. Can you hear me well? Okay, so it seems that many people are quite familiar with verbal autopsy. So the topic on the community cause of death, even we mentioned about the new initiative, but very few people attended here. So anyway, because that's the new one, so it's a good chance for us to share with you. So the first, let me introduce a little bit more because the okay, can I give this one? So uh, most of that in Vietnam happen in the communities. So but the data, so we try to find out the one of the solution to improve the data, because that's crucial for the mortality statistic and for any kind of decision making policy. Before I present, I would like to acknowledge my partner and implementing technical partner and implementing partner from MOH and the provincial Department of Health, and also expert from the vital strategy, and many people I list the name here, so I don't have to repeat it. And also we also recognize the support from Bloomberg Philanthropy. Yeah, without their support, we cannot make the pilot and do any kind of assessment. Um, and here is the some of the overall background for the why we make the pilots and what we mentioned about the um, new model or the new or initiative for this one. The first, for the common understanding, actually, unfortunately, we do not have the official number of the percentage of death in the community or in health facility. That's still very, that's the issue in Vietnam. But the common understanding is about 80% happen in the communities. And under current system, I mean for the MOS assignment, they assign for the community health station to take charge in for the monitor the death, including identify the cause of death and recording and reporting it. Now we have a digitalized system already, so on the reporting have a digitalized. Um, However, the MOS doesn't make any very we call it standardized tool and protocol to ask for the to change for the community health station to identify the cause of death. They still try to change in general thing what is the cause of death to report for them, but no standardized form so far. And in addition, in Vietnam, we also try to apply to test some of the verbal autopsy WHO recommended, but still a lot of argument and about the cost for implementation. So MOS doesn't accept it to work in Vietnam. That's why, and based on our previous vital also support on using for medical information, EMR, not we do not have the electronic medical record. Yes, we still use a paper base. Now we changing for the EMR. So, but we based on previous study found that is if we have some medical information, the identify the determine cause of death is more confident, yeah, and more reliable. So we take on that and combine, and we also take the lesson from Thailand experience. So we combine for the first, we do some kind of structure questionnaire, household interviews, so we can get the basic information about the um, medical history and the symptom and any kind of the event before they die. And then we also in Vietnam, we have already collect all of the his treatment care and treatment history when the people visit for hospital. So when they finish for the treatment, the hospital also transfer the information to the we call the electronic health records. So the information already somewhere in the cloud. So we try our method also try so the physician in the community health station will have the chance to get some kind of medical information in the electronic health records. So based on the household interview and the electronic health record information, the physician at health community health station, now we make some kind of the sequence for cause of death, and then the identify for the cause of death. And here is you can see the some reason for the study side. Actually, we call the pilot, but in the study, you can call the study side. We use in 2 provinces in Nghệ An from April 2024 to the March 2025. And it covers about the 60 community health station and cover more than 600 population. The pilot also include because we do the pilot and we do some kind of intervention. So we also provide the training for community health station. They can know about the procedure, also the tool, and also we train for the supervisor, also support for the implementation as well. And for the data capture, for collecting the data from the intervention, we use for the existing the SIS, the District Health Information System. You're familiar with this? So we still use the same, but we customize a little bit before we only capture for the original, we call the original cause of death. That means whatever the family talk to us about the why they die, why their member die, they will record it. But now we still keep that information, but we have another cause of death after we apply the process that I just present. That means interview, look at for medical information, and then combine them and make for the sequence. And then for the actually we because the pilot, the vital support. So we do for the technical assistance regularly in the period of time. And each time we will look at for because they need to fill in for the questionnaire. We have a structured questionnaire. Also for the form to retrieve for the electronic health records. So every time the technical assistant provider come to the field, they also look at for this one to check. And after for the sometime we also organize some kind of the round table like this to discuss some case conference to figure out any barrier and any kind of the thing the people can learn from each other, because in the past they just simply write down what the cause of death. But when you apply for this one, a lot of things more complicated because a lot of more information to need to assume to diagnose. Yeah, so it's more complicated. So capacity building also along with this process. And then that's the reason why I said we combine many resource information to evaluate. So for the result, so we think is more reliable. And to compare, and you can see here, to assess for the effectiveness of the program, it compare between the appreciate the initial cost of death and determine cost of death. If they're changing, so that could be the better, right? And particular have a true evidence here because in the past, many of them is the senility, that means the old death or something, and the unknown cost. So that means if they reduce, that means they have a more meaningful value. And here you can see for the information about the death in the study site in district. Here is very in detail, but you can difficult to see, right? But you can see the some of the picture anyway. The almost of the month is fluctuation, but the female the male is more than male, a male more than female for every month. And particular in the mean and median age at death for the female is much higher than male, almost 10-year difference. That means female is longer life expectancy. And look at for the what is called the variation distribution. I don't know. By the scatter diagram, you can see the more people is rather in the old age group, and but for male, it still happen a lot in the younger age group. That means they can die. We have a lot of information to can have a explanation to discuss here, but in the short time, I cannot provide many. And also here also show for the place of death, most of the death happen outside of the hospital. Hospital is very few. You can see in the very few. And also as you used to think to remember about the medical when you apply for medical records, they also mention if the patient, if they have a treatment withdraw the 13 days, so they rather confident that the last treatment could be the cause related to cause of death. But most of the cases happen more than. Yeah, but that's based on the current electronic health record we have. But actually could be more people. Sorry for the time, so and in here, so the main result of the study, we do many things, but only so for very important. Here is a cascade to show it's not better. But in here, you can see the changing the changing in the lead of the sorry the changing of the of people die by the different. Before you see salinity is the 28%. Oh, sorry. I think I speak bigger enough. Okay, but before it's the 28%. After it's only 16%. And also the unknown is still low, but it's still 5%. It's now only 1%. And look at for the detail. For salinity, still have a lot is still unchanged, but many of them have changed because you know the many die at the age, but they have no information on electronic health records, so we cannot change them to assign them for any kind of the others. And also some increase here, but the time I cannot. And for the effectiveness of the model is very simple because in the past that simply pick up the what people say, but in the new model at least we combine both, but we ask the specific question. In the past we don't care, you can provide me whatever. Now we combine with the medical information from electronic health record, that means from hospital, so it's more reliable, right? So as I mentioned, we do a lot of technical assistance visit. So in 8 of these visits, we also compare between the community health station, they identify the cause of death with the technical TI provider. You know, we also have national expert come together, but we compare. So we found that it's reliable and can acceptable. For more detail, another study will show about this one, but in general, I can provide in that one. And the impact, you can see, even with that talk about the some of the small insanity and unknown, but actually the 63% have a change. It's quite simple, like the people die by cancer. We don't know about the primary cancer. We concerned about the primary cancer. We don't care about secondary cancer, right? So, but for family, they only remember the last treatment, something like that. And also the medical records in electronic health record, for example, people die young, by SIV, for example. But normally, family only mention about sudden death. But when we look at for electronic health record, they record that they are the SIV patient. So at least we can refer, if they have no accident, something, yeah, so we can refer that by SIV, not by unchanged sudden death. So I, and okay, so the novelty also, here that the some you can read very quick. We also, as I mentioned, we also take the lesson from Thailand, but based on electronic health record, we can accept actively. In Thailand, they have a tool because they have very good system and EMR, but they need to permission in each hospital.
Sorry, Joe,
Yeah,
if we could, because we've gone
sorry.
way over time, and I do want the other two speakers.
Yeah,
Maybe some of these things, I'm sure it would come up in the question and answer session as
yeah,
well,
sure.
in terms of the integration and how you manage to do it. So I would urge everyone to note your questions for Joe, especially I think countries that are looking into community cause of death. I think they will have a lot to learn from Vietnam's example. So we'll move over to Jane next. Thank you, Joe, for your presentation. So we next have, thank you. We have Jane presenting on the effectiveness of community health folks in improving mortality reporting in the Kakamega County in Kenya. Over to you, Jane. Thank you.
Thank you so much. I think I want to save us time and also having to move around. The topic is on leveraging community health workforce to improve mortality reporting. And we're using evidence from Kakamega County, Kenya, western part of Kenya, where we conducted a verbal autopsy initial implementation. We, in our government, we don't call it pilot. It's either controlled deployment or initial scale. I want to acknowledge the ISCAP, ECA, the Vital Strategies, and overall the Bloomberg Philanthropies, Digital for Health Initiative for supporting this. And next, the problem is that Kenya has the death registration completeness is about 44%, and it's been between 43 and 47 for so many years, as reported in our KVSR, Kenya Vital Statistics report. And what comes out at 44%, half of this 44% of the deaths captured in this completeness are actually community deaths. And also the ones that are not captured, that is 100 minus 44. Most of them would be for community deaths. So we have an average of about 70% of deaths in Kenya happening outside the health facility. And so what we're looking for is when we're conducting the pilot, we use CHPs. CHPs is community health promoters. And the reason we're calling this community health workforce, not to cause confusion to you, is because we have various cadres of community health workers. We have the CHP who report to the community health assistant, who is the CHA, and many others in the chain. So we just call them community health workforce. And we have a network of like 120,000. And so registration in the community is done by assistant chiefs who are our registration agents. So we're looking to leverage on the CHPs from the Ministry of Health, whereas the assistant chiefs are domiciled in the Ministry of Interior. So the benefit of this project is to evaluate the effectiveness of health programs and to track progress towards SDGs that are death related, particularly target 16.9, and also to know where resource allocation should go to, and to develop policy, as you will see in my recommendations. But most importantly on this part is the amount of support that the government of Kenya puts towards primary health care at the local level, the community level. So the methodology that was used for the methodology that was used for okay, fine, thanks. The methodology that was used, we used quantitative descriptive research. And for the period under study was January 2024 to December 2025. And we noted under the Ministry of Health, Electronic Community Health Information System, where the CHPs report the deaths, we had about 8,270 deaths. Whereas in the civil registration system, the Ministry of Interior, who are the legal notifiers and registrars of death, they had 6,832 deaths. This is what we found out in that county. And so what we did, we tried to understand the category of deaths that is not being captured by the Ministry of Interior civil registration system. And so I used our statistical package, which you can match the two data sets, the one in each Ministry of Health and the civil registration system in the Ministry of Interior, to match the deaths and then be able to see what are the characteristics of the deaths that were missed out by the civil registration. And it is an analysis. The analysis is age and sex distribution, marital, and also sub-county. And you will see the orange bit is the extra deaths that were captured in the Ministry of Health. So really this is age, analysis by age. You can see 5 to 11, the 90. I really want to save time, but you can see the figures and the rest of the figures when it comes to contribution by sex, distribution by sex. So the blue is the CRVS system. And the orange, like I mentioned, is the extra deaths captured by the ICHIS. So an addition of both would give you the total number of deaths under ICHIS. This is the distribution by sub-county where the death was captured, and this is by marital status. You will see again the orange part is the additional deaths that were not captured by the civil registry, but were captured by the CHPs. One of the things I need to point out in the Ministry of Health, the CHPs work at the household level. So they are assigned 100 households and they visit regularly. So one of their among the many things they track at the household level in this ICHIS is deaths and also births. They also track pregnancies. They also do WASH. They also have equipments or items to track hypertension and also diabetes. And because they're also attached to a clinic, they also do referrals to the clinic for people who are deserving. So the findings and discussions is that the Ministry of Health, ICHIS captured more deaths. So the difference of the 8,000 and the 6,000 would give 1,439 more deaths in the ICHIS. And this is because there was sustained sensitization by the government. Of course, as I mentioned, Kenya has really invested in primary health care. So the CHPs and CHAs have community trust, and also they are recruited from the same community. They are visiting regularly. Now, remember the assistant chief from Ministry of Interior who registers these deaths does not go to homes, does not visit houses. So, and sometimes some of the sublocations are so big and they don't have a chief or an assistant chief. So sometimes they miss these deaths, and this could be attributed to the fact that Kenya's registration system is passive, but the CHPs or the ICHIS Ministry of Health system is active and could possibly activate our registration system. So there was low infant mortality. As you'd see in the group, there was 0. And this is attributed to, I think, targeted medical and public interventions. Again, remember I mentioned the CHPs track pregnancies and refer them. So we have reduced our births at home. And Kenya has 99% of births happen in the community. But then again, I would mention a disclaimer, we are at 70% birth registration completeness. Then the ICHIS system is effective in capturing unnatural deaths in the communities. This is very important for us because of the medical legal aspect of deaths. And because again, under the ICHIS system, we have signals. So even it's event-based surveillance, and at the same time, there is a route for signals. So we're able to know that there was a wrong traffic or there was certain death, even if it's not exactly going here, it's going to have our MCCD, it's going to another system, but we'll still be able to have the signal. Other countries, this is a recommendation for other countries. I did hear Uganda actually yesterday mentioned they have ICHIS. if I'm not wrong. So it's a recommendation for other countries to actually explore the electronic toolkit, community toolkit, as it's called. Recommendation and next steps is adoption of CHPs as death registration agents by the Department of Civil Registration. This is something we've begun working on. It will require a legal review. We have a birth and death registration bill 2025 that has actually had a clause on this. Then the Ministry of Health issues system linkage with CRVS system. The CRVS system in Kenya is actually paper-based, but the Ministry of Health systems, whether it's KHIS, is they're all digital. So linkage of those systems will really work. Introducing a unique person identifier field to be captured on data collection. This came up because when you need to, for example, when you're using R and even data, matching two data sets would require unique person identifier. So most of the fields were missing, and it's a discussion we have with the Ministry of Interior to ensure all the deaths have a UPI so that we can easily capture. Then we need to research on comparable programs. It wasn't just death, we can do birth, we can do even immunization and many others, actually even on NCDs. And the next steps is presenting the recommendations to the leadership of CRS to inform policy making. Thank you very much.
Thank you very much, Jane. So we still have, I think we can do a few questions because we can have 5 minutes for Q&A for Jane before we move on to David. Any questions in the room? Sure. I think we have one, Dr. Abhishek.
Hi, it was a good presentation. I would like to know how did you match the data? You said there is a requirement of UPI, personal identifier. So how did you match the before two data?
There's the ID, but it is missing. There are certain entries that were missing. So
yes, that is missing. But how did you identify two data were common?
Sorry?
Like you had some 8,200 data. Here
we
some
went all the way down. There were not many fields anyway. So we went all the way down. We went all the way down to even sublocation, to the names, to everything. There were not more than 12 entries, but then we recommend that strictly no entry, no notification should go without a UPI, which is the national ID. Because also we also use the serial number for the
so use the same UPI for this.
The ID number is the same
Okay.
on both sides, Ministry of Health and
Okay.
on Interior.
Okay. Thank you.
Thank you for raising that question. I did have the same question. Go ahead. Yeah.
Thank you. And thank you for the good presentations. My question goes to Cho. How does the community cause of death questionnaire used in the model presented determine the underlying or immediate cause of death? What is the algorithm used, and how is it different from the 2016 WHO VA questionnaire, autopsy questionnaire?
Yeah. Yeah. Hello, can you hear? Okay. So for the we call it a structure household in household structure questionnaire. Actually, we not rely on the VI questionnaire. We develop based on we have the technical working group on the cost of debt, and we pick for some key of the information, and I also just lead out. I can share for the form as well. We look at for the history of medical history, and also for the symptom of the before 24 hours before they die, and also the medication something, and also any kind of event like this. We just concerned because some people die, maybe have the medical treatment, and also have some of the accident, something like that, to reduce. Yeah, so actually we do not apply for the VI. And for the develop, and your question actually I'm not quite clear about, but it seems about the how we develop for the sequence um, season cost leading to that, right? So as I mentioned, we combine some kind of reflect between for the household interview information and also for the medical information history in the system. And then based on that, we try to make for the household the um, to assign for the sequence. How explain, but yeah, okay.
Yeah.
How
So,
can
so I was just going to recommend that, Yacho. I know I've seen those questionnaires, so I think it's worth sharing that. So maybe during the coffee break, you could also like share contacts and maybe share what the questionnaire looked like. So if you're interested in seeing how it differs from the WHO VA questionnaire, I think there's a lot more technical details, and there's also country coordinator Hom who's present in the room. So maybe a chat with the country team would be helpful. So with that, another round of applause for Jane. And then we'll move over to Dr. David, presenting on bridging gaps in mortality data, strengthening cause of death reporting through community-based surveillance in northern Ghana. Thank you, David.
Yeah, thank you for the opportunity. I think once you spoke for 11 minutes, I will speak for 30 minutes. Okay, so the discussion since morning has been that we need to count our debt and we need to register those debt. In as much as that is important, it is also even critical for us to know what causes those debt. Okay, so and it becomes difficult to do this usually in areas where you lack medical personnel to be able to satisfy these cause of death. And so we looked at community level deaths and what available opportunities there for us to be able to improve death reporting and also establish cause of death. So we did this with the thinking that, in most sub-Saharan Africa or low middle income countries, we have these issues of weak civil registration system. And coupled with that, we also have most of the deaths occurring outside the health facility. So if deaths are even occurred in health facility and they are not reported, they are not cause of deaths are not established, how much more community deaths? And so we tend to look at this in the context of Ghana. So in the case of Ghana, we actually have some periodic surveys that seems to capture deaths, like DHS doesn't capture deaths, but at least it collects some information. And we also have multiple indicator surveys. We also have the Ghana medical health surveys that collect some of these things, but they do not capture real-time information for us to understand the causes of death. So in this context, at least we think that verbal autopsy would be a good replacement to record this cause of deaths. So what did we do? So we collected data from the Navrongo Health Research Center, which was established in the 1980s. This is because this center collects information on births, deaths, and migration. And so it's able to capture, it has a population register of the people, and it's able to capture deaths, migration, and mortality as well. So we think that it is a model that we should use to analyze and be able to inform policy or at least guide policymakers on how to at least report or record these causes of deaths in settings where you do not have the medical certification for causes of death. So we took data from 2012 to 2018, which recorded a total number of about 6,000 deaths. And we realized that some of the deaths that, oh, sorry, I think I've gone far. Okay, so there were about 46 missing cases. So we did analyze 6,152 deaths. We use a mixed method kind of thing to understand this phenomenon, particularly where we are dealing with community level. It is important to do the quantitative using the numbers to project, but then also to collect community views, perspectives on how this system, whether its acceptability, its operational functionality, and all that. So we did that with community health research lead. We focus on health research officers. We focus on community leaders. And what we did was to, as I did mention earlier, is to look at acceptability, operational feasibility, data completeness, and how we can use this data to inform policy. I do not want to bother us on how we go about with the verbal interviews, because I'll be coming to that. So what we do, the Navrongo Health Research Center, what we do is that, so there are community key informers in the community. So where deaths are occurred, they are reported. So they are more or less like, they are in the community. So when deaths occur, they virtually they are aware of it. So they report these deaths promptly to a health research worker. Okay, so who then follows up? Yesterday we talked about sensitivity in cultural context, where when there's what time should we go for interviews? Should we immediately go and find out what is the cause of death, or we should postpone? How long do we do that? So community key informants report the deaths, and field workers then follow up later to conduct verbal autopsy interviews using a standardized, questionnaire. And what the center does is to then do quality checks to see whether this data that we've collected, to ensure that at least there's accurateness in the information that they have obtained. Then the data is then given to physician assistants to then assign probable causes of death based on the information obtained. Okay. So what did we find? We realized that about 71% of the deaths that occur within this period occur outside health facility, meaning that if verbal autopsy was not used, we could miss counting these numbers. We could miss the causes of deaths of these numbers. So what then we are trying to argue here is that without community-based surveillance, at least these deaths will go missing. And we've started this debate about, knowing the causes of deaths prior to the Millennium Development Goals, and then we are currently in Sustainable Development Goals. So if community deaths are missing, what is going to happen to our health planning and all that? We realize that of the causes of deaths, non-communicable diseases, were the major causes of death in the community setting. This seems to contradict the, the popular views that, in poor areas is usually communicable causes of death that lead. And in terms of specific sex-specific mortality, we realized that most of the deaths that are associated with non-communicable causes were with men, and then communicable causes is women who suffer the most. Okay, then in terms of the top 10 specific causes of death, okay, so these were the 10 specific causes of death. We realized that cardiovascular diseases, transport accident were more predominant. Of course, malaria, we said we eliminated malaria in certain settings, but we still have it. And, liver cirrhosis also came the number 10th causes of death. But in terms of trend, we realized that, okay, normal NCDs are actually declining, but, it's still high in the area, and it is also in an association with communicable causes of death. Well, we also realized that many of the deaths were unknown. That still leave a little gap when we talk about verbal autopsy. Okay, but at least in settings where we do not have the rightful architecture, I think verbal autopsies. So we're saying that, well, in the setting where we did the study, there's this double burden of diseases that we can talk about with the coexistence of NCDs. I'll be on time. Yeah, thank you. With NCDs and communicable causes of death still existing as major drivers of causes of death. And at least the report shows that NCDs are actually declining, but still on the high side. So we think that at least with community surveillance, it should be the right way to go. It might not be the golden standard, but situation where you do not have, digital platforms and all that to do, at least this works for us. So in terms of, improving CVRS, we think that at least the role of community key informers are important, and at least we should prioritize and adopt, mobile real-time death notification, and so that we can improve, cause of death reporting. So we think that at least implementing real-time notification of deaths by the BDR and then other Ghana Health Service and all that will improve death registration in the country. And at least we need to invest. I must admit that verbal autopsy data do not usually just come so easy. So at least there's a need to also deepen community involvement with local leaders. So as for them to understand this, before we did the presentation, we were talking about some people don't even know why we need to count people who are already dead. Okay, so we need to do that. So by way of conclusion, at least using the verbal autopsy interviews, at least about 94% of the deaths were accurately classified as a particular cause of death. And this gives a very good sign in areas where we do not have some of these technology and all that. It could help to, improve data. At least it could data reporting. It could help us in decision-making process, and maybe it may help improve health outcomes. Thank you.
Thank you very much, David. Before we move on to the speaker panel, shall we have questions addressed to David specifically for his presentation, if any? Yeah, please.
Thank you so much, David, for that presentation.
I can answer that.
Yes, please. My name is Stephen from Zambia, and I think it's very interesting to see the verbal autopsy findings, which are very, very similar to the profile with what we are also seeing in country. My question goes to what are your thoughts on, or what stages is it at in terms of integrating these cause of death outputs from verbal autopsy? I think from what you've just presented, over 70% of deaths are happening in the community. So that's quite a huge proportion. With integrating them into routine CRVS reporting, are these findings making their way into some of these official reports? Then the second one is on the representation. I think it's tied to the first one as well. Oftentimes, the criticism that is there with information coming from an HDSS site might be that it might not be speaking to the entire picture. But I think your thoughts on how perhaps the information from an HDSS site could actually be maybe different approach, could be made more scalable to have actual national representation.
Yeah. Thank you so much, my brother, for that question. And I'll start with the issue of HDSS side. That's very true. So the debate had been whether, because I made a point that these sites usually they are able to monitor a closed population, and so whether approaches that are used in those settings can be applicable in the national scale. Yes, I think I did admit that it's expensive, but I think that with a model that the NDSS sites are using, the HDSS sites are using, if national policy makers adopt that kind of mechanism, it could help to improve data reporting in many of these settings. And I think that is gradually gaining grounds. I know some work that is being ongoing in Ghana with the NDSS side and BEPS and DEV. The BEPS and DEV's registry made a presentation yesterday. Ghana Statistical Service will be making presentation. And I know that these bodies work together so that the lessons that we learn from this HDSS side can be applied to the national level, at least to improve, upon data capture of this population. I admit that it's really expensive, but if you look at the population where this study has been done, that's about 190,000 population. That's quite huge. So it should be able to present a model that can be applied in certain settings. And then the other question was about which one? Sorry.
How these findings are being integrated into CRVS reports, if at all, and if there are any plans.
Okay,
Yeah.
okay, then maybe I have just answered that question because I've made it the case that we there's that system that we work with, the births and deaths registry, because the births and deaths registries, I think they are also now trying to adopt this community notification system that is being used at the NDSS side, so that when deaths occur in the communities, then they have, I think I have a colleague here who can even speak to that in detail. So they have a personnel that would, get the information to the BDR officer, and then the deaths are, promptly captured. Of course, I know that BDR do not do causes of death analysis, but at least once the death is reported and captured, then it should help in this thing. So yes, it's being integrated into the national.
Sure. Great.
Yeah. I know you said that expansion is expensive, but I think I would argue otherwise.
Okay.
I think from your own stats, if decisions are being made on that 30% that actually get reported on, chances are those decisions are not cost effective if they're being made on 30% of data. So I think I'm playing advocacy for you to say,
I know, right?
Yeah, the 70% should justify any cost consideration if the population, more people are dying in the community. Any intervention to capture those deaths in the community is cost effective, and not doing that is the expensive decision.
I know. I get that point. That's true. When I was making the point about it being expensive, Navrungu Health Research Center recruit field workers, train them on this WHO standard instrument, how to conduct the interviews in the local dialect. In fact, I myself went through a training, and how to even interpret the questionnaire in the local dialect is quite intensive. So that's the point to which I was coming from, training field workers, letting them to understand. In fact, yesterday or 2 days ago, my mom called me and said he went to the community clinic and they said her blood is over. That's BP. How to even say it in the local language is a problem. And we need to train field workers to be in the field, the community key informants that we are talking about. At least they need to be given some tokens, or else somebody whose business. So that's the point I was coming from. But I think I take cue from what you are saying, because if we 30%, we are not making decisions from 70, it is even costly when we don't. Yeah. So
Thank you. Thank you, David. I know Home has a question, but before you go, if I could just channel one question to Jane. So in terms of, I was just wondering, like you did show in your presentation, the additional deaths that was captured by the community health information system. And I noticed that pretty much across all the analysis that you did, it seemed like the similar percentage, like a 20% increase, whether it's by sex or location or marital status. And it didn't seem very like there were any equity issues. But when you presented the discussion, you showed that like the road transport accidents, they were picked up more by the HS system. So I was just wondering whether you already have analysis of what it shows by types of deaths, and maybe that's something also that can advocate for having this kind of linkage. So
Yeah, and you're right. That is what came up in the data. But the reason I left cause of death analysis is because the government intends to launch the report. So I didn't want to preempt the
Okay.
government, even if it's D4H support, and it will be wrong. It's government's
Okay, great.
Yeah.
Thank you. I just, because
Yeah.
it was there in a tiny bullet, but that seemed to be such an important aspect of
It
your
was very-
analysis. Yeah, yeah.
It was very important because, like I mentioned, the two systems, there's the signals. What came out from the field, from the interviewers, is they would hear there's a death in the community. They would quickly dash there. But the way we developed our verbal autopsy implementation guidelines, we uncovered that you cannot conduct verbal autopsy until a notification form. And so because we have two forms, the community and the hospital, when they go for the VA for RTAs, they would know they got a notification for the hospital. So it was a good thing to notice that they're actually knowing these dates exist. Yeah, thank you.
Thank you. Thank you very much. And Home, over to you.
Thank you for your presentation. My question is to David about verbal autopsy. I think it's a very interesting analysis and produce a lot of useful information. My point, there are 2 points. One is related to the technical things. First, about the tools, the verbal autopsy questionnaire, you apply the same WHO one, or you do adjusted one for the country? Because I know that some country they just adjust it and do and implement. And then it comes to another questions of if you want to use this result to inform policy for national scale up or something of the using verbal autopsy for community cause of death in your country. So in this study, have you done a validation, VA validation? Because it's very important. If you do that, and you will be better informed for the policy. And the other aspect that I think that Joe mentioned during his listening is that this you do the data analysis for the year 20. I think, and yeah, but it doesn't matter. Recall bias. We think about the recall bias. Yeah. Yeah. So is there any issues related to the recall bias, and then is there any adjustment around that? Yeah. And the last question about thinking about recommendation for national scale up or integrated into the CRVS system. I think it need to and it needs to a lot of discussion around, and like what yeah, one guy had been mentioned, we need to do the like a cost effective analysis, because like in Vietnam, we are based in Vietnam, the government quite consider about the cost to implement nationwide, and we have to think very carefully about the strategy to apply VA in the country. Yeah, thank you.
Okay. Yeah. Thank you so much for the compliment and the questions. On the issue of the questionnaire, the Navrongo Health Research Center uses the standardized WHO questionnaire that is being used in the health and demographic surveillance sites. And so the same questionnaire that was used. So the issues of its standardization would not be much of a problem. And if you are asking of validation, so I did mention that the center has, so there are 3 surveillance sites in Ghana. We have one in the northern part, one in the middle, and one in the southern part. So these surveillance sites have been in operation. As I mentioned, this one was established somewhere in 1992. And so validation of these tools, they are even using standard tools. So the community level validation have always been done, because they kind of, every project that we have, they hold a community stakeholder engagement, and the results are usually presented to community members. Of course, causes of death will not be the one that they would come and present, but at least these tools are usually being validated before they are used. And then recoding. the center uses the ICCD 10 coding system. I'm not a medical expert, so I may not want to go into details on how the codings are done, but usually 3 physicians are brought in to, analyze and assign the probable causes of death based on the information that are being obtained in the questionnaire. And so where these 3 physicians assistants, when there are disagreement, I think they go again second time, and then finally a probable cause of death is established. Okay, so those are presented as 6% or so of the deaths were not on, the causes of deaths were unknown. What it means is that there were not sufficient information that could establish the probable cause of death. So that is what I can say for now. But in terms of the scale up, well, we've made some recommendations that at least policymakers and implementers can at least should adopt, and to be able to make this in a wider scale and helps to improve cost of death. The point I would always make is that there's this joke in my country about, and I know you are so familiar, the road to Kisimu. The road to Kisimu is about a village rider who is riding a bicycle and using Google Map. And in settings where Google Map does not work so well, the Google Map took the man and said, this is the right road to Kisumu. He got to the place and there's a river he cannot even cross. So whilst we recommend technology and all those kind of tools, at least we should also be mindful of settings where some of these things cannot work. And so I think VA still maintains the golden tool for some of these settings. Thank you.
Any other questions? Yeah, sure. Go ahead.
My question is Dr. Cho. I would like to know the availability of medical records. So, was it available? Was it adequate enough?
Okay, the first medical records. Yeah, medical records in Vietnam, we are now in the transition from the paper-based to electronic for the EMR. So because the Sakai, the system is a hospital-owned system. So if you want to look at this, you need some kind of authorized to work with the hospital leader to get the approval. So that's the why. But many of the information in medical records will be transferred to the health records, electronic health records, because in Vietnam is if you come to the hospital treatment and reimbursed by the health system, by social health insurance, so such kind of information, that's some kind of supporting document, so they will be transferred to the social health insurance. And in MOS, they found that this such kind of information very valuable. So they also pool such kind of information and to store in that's called, we call it the electronic health system. And in the community health station, they also have some kind of account to get access for this system. And they can get to look at for the treatment history of the resident in the catchment area. Yeah, that's why we promote for such kind of this one and reduce any kind of to administrative procedure. Yeah. So medical, yeah.
May I just on question? Yeah. I'm Hồng from country CRVS country manager for Vietnam, Châu College. I would like to just elaborate a bit about this. So basically, the overall idea of this model, we call the CCOD model, community cost of death in Vietnam, is to try to combine, to utilize the use of information from the medical information from electronic health record with the piece of information from household interview, to combine two pieces of information to a certainty cause of death using a a simple MCCD form. So the tools using in this model, including 3 forms. The first is a household interview. It's about 1 pages questionnaire asking very short information about the last medical treatments and what is the condition or disease appear within 24 hours before the people die, the patient die, and what happened from the discharge until die. Because usually Vietnamese people want to stay at home, to die at home. So that's why we try to identify what happened between the last treatment until they die, either any accident like injury or something. So we combine that information in 1 page, and we train the community health station physicians to do the cause of death ascertainment following the MCCD form. All right. So and then regarding to the availability of the electronic health record in the province in the site study, when we do the study, it's about 97% of the population in our study site have the electronic health record. Of those, about 90% have information, because some is empty. They just create, but they don't have any information. Yeah, and so it related to Stephen's questions before about what is algorithm use, because we don't use verbal autopsy. It is not a verbal autopsy form, and we use MCCD simple form to ascertain the cause of death for the community, and we use we apply the list of 81 causes of death in the community according to one circular from Vietnam applying for community death, and we just compare what happened. We compare the cause of death before and after the intervention, and we we see a lot of difference. And the big amount of percentage is in the ill-defined conditions, and similarly, like OH reduced dramatically. It shows the effectiveness of the intervention, and it is it informs for the next step that this model needs to be extension in a wider geographic area to continue to standardize and to complete the process and the tools. Yeah.
Thank you, Homan Chow. Did that address your question? Was it also about like accessing medical records? Okay, so I think in terms of you addressed how many of the population had electronic health records, but also if you could just briefly add on how were you able to have access? Like did the regulatory environment allow for that? So maybe a little bit other settings which are looking into this kind of model, maybe it'll be helpful for them to know how you got access to the electronic health records. And yeah,
because not health records, medical records are not preserved in India.
Yeah.
It is mostly destroyed when the death occurs. So we have some challenges. So I wanted to know how it is.
Yeah, in terms of accessing that information, if you could just give any, yeah.
Just quickly, for medical record, we need to obey very strict permission. We don't allow to access. But what we apply here is electronic health record, because in Vietnam we implement electronic health record when the information about briefly information about every treatment will be pulled down from the medical record in the hospital to the electronic health record. And in Nghệ An province, where we do the research, when we do the intervention, they have a very good system. They operate very good system and on electronic health record. And one important thing is that the community health station physician is officially allowed to access the electronic health record to see the medical history of the patient over the year. Yeah, that is an advantage when we do this model.
Thank you. While there are other questions, maybe from the room or online, I just would like to ask all the speakers. Like I think what David mentioned about the road to Kisumu inspired this question. So each of you have outlined your community health strategies, like from surveillance sites to linking health information systems to the using medical records. So if there are people from different country settings here, and of course they're interested in the different models and the successes you've shown. But if you had to tell them, like, what are those like 1 to 3 key prerequisites, right? So that you're not handing them a Google map in an area where they're going to run into issues. So if you had to, yeah, give guidance on, yeah, so of course, maybe to begin with, yeah, having access to medical records is important for a model like that. But if there were, yeah, 1 to 3 points that you would like to highlight in terms of how your strategy could be successful in another setting, or something for people from other settings to keep in mind while they approach your study and findings. Thank you. Starting with Jane, maybe. Thank you.
Thanks for that question. I would say the first strategy is stakeholder engagement. All the way from the bottom, the interviewers at the community level, to the top government. Because for us, there are two things for Kenya. One, the registration services are a national function. It's a function of the national government, but the health sector is actually devolved. It's a function of the county government. So you cannot engage one over the other. In the health sector, the national government just gives policy directive, the county governments implement. So we had a lot of stakeholder engagement for them to understand why the verbal autopsy pilot was very important. And for us even to access the records, because we had to check the death records as well. Besides, let me say this, at one point we had verbal autopsy on retrospective deaths, and we also had verbal autopsy for current deaths. And this is because in studies you want to compare cause of death that was assigned before and cause of death that is assigned now, and especially because it's lay reporting initially. And so this stakeholder engagement at a policy level, you need to get the consent. Usually when they understand what verbal autopsy is, and it's an old concept in HDSS, but it's a very new concept in government itself, especially at the national level. You'd be surprised how there are so many experts in the country who are doing verbal autopsy funded by donors in HDSS. But no one knows that. It was not understood at all at the national level for Kenya. But after we engaged, then later noticed you need to educate. So one time we had a very high level stakeholder engagement, and at the end of the 4-day, when we had the staff from New York as well, the data for health and vital, the senior directors asked, but what is verbal autopsy? It's the end of the workshop, but they're asking what is verbal autopsy. Now that question triggered us to understand that, you know what, you need to teach. Yeah, you teach them what is verbal autopsy, then now sensitization comes after. So this buy-in that we were seeking did not come immediately because people did not understand what verbal autopsy is, even if we had a whole room of HDSS people who had been doing this. So to me, the strategy is stakeholder engagement, where you get to know the gaps that exist in the understanding of verbal autopsy. And if you need to teach, you will need to teach, you need to engage. And after the buy-in is sought, they will actually give you the documents. If you want the EMRs, we are able to access, and we've done it before, but still there was need for the right body to give consent and for them to understand why we're doing these assessments and the studies. Yeah.
Okay, thank you for that question. And I think I agree with Jane in almost all the points she raised, because I would admit that the success of the verbal autopsy in that kind of setting is because the NDSS side had been there for long, and several policy interventions, educations, community engagement have really taken place, and the community have come to accept, that kind of institution, and it is easy to identify worker or researcher from that institution. And so it's possible that trust is strong based on the community trust. So building community trust is key, and that would have to do with engaging with community leaders for them to understand why you should even do this, because the person is dead and gone. I'm mourning, and you are coming to, remind me of what the person have gone through before passing. And so community sensitization, community engagement is really important. But the next point I would also want to capture on is at least to scaling it up to the national level. Most of these things we usually need the policymakers, the politicians, the buy-in of policymakers, or else the research will just come and present here and it will end here. I presented a paper in Australia, and that time there was some politicians were there. Somebody walked up to me and asked me, as you are presenting this, is your MP aware of it? And I said, no. Then he said, then this will not go anywhere. So at least there should be a link between academia, research, policymakers, and implementers. So in the room where you are presenting some of these things, there should be one of them who should understand why we're doing these things. And I think the national buy-in is important. And yesterday, a colleague of mine, he was a co-author, Dr. Charles Hasaber, he's sitting at the back. He made a case for, debt registration and that in Ghana. And the need to, we have a legal framework, but then it should be enforced. So legal frameworks are also important in being able to do some of these things, because you cannot go to community level and say, I'm coming to find out why Mr. A, died last week or last 2 weeks. What made him to die? If you do not have the legal, mandate. So in brief, these are some of the things that I think that if you want to, adopt this road to Kisimu, you should think about it in that kind of thing. Thank you so much. Yeah.
Okay. So the Chu have mentioned a lot of things, so I don't want to repeat, but I want to echo for the Chu key point for my presentation, but it's could be it's not clear enough. So I want to echo a little bit. The first, because when we mention about the initiative, so it's a very important, it needs some kind of the effectiveness of the model. So that's why it should rely on the current system. Everything is existing. The personnel, the human resource, infrastructure also should be there. We don't need to create anything new. We just to modify for the business process. That's why it's very necessary, because when we mention the government, because we do the pilot to transition to the government. So the government always concerned about the cost of the implementation. And because we increase any task, you need human resource, every investment. So that's the thing. And the second thing also is not about the conflict with the VI. But when actually in myself, I also coordinate for the VI work in Vietnam before I joined the vital strategy. The VI is okay. It's a method, it's very easy to apply in the communities, but the implementation is not easy. And particularly, I understand the home question, because when we know about this, in every country, we have some kind of the technical team, the local one. They also have a lot of influence for the MOS to accept any kind of the initiative, even recommended by WHO or anyone else. So that's the also we need to convince for these influence people on the effective of the methods, because I'm again not about the VI, because it's easy to now, because the most of the people is a medical background, so they very concerned about the medical support information for this one. So that's the reason we think is everything should have the technical thing and also the political thing about the money, because we can advocate for the donor. It's okay. We do the small pilot. It's okay. But when we want to scale up, we need something is very practical, cheap, and the existing system. Yeah. Thank you.
Thank you very much on that very practical note. And we are right home. Do you have one last question? Okay, maybe one last question. And also, I think, comment? Sure. Why don't you go ahead? And then before we end, Jane has a request to make to the audience. So first Home and then Jane.
Yeah.
Man from the Vietnam team, when Mira have a very great question about what the panelists have a recommendation for other country. So we are sit here to talk about the community cause of death, right? And we usually think about verbal autopsy. We are not against verbal autopsy. Yeah, it is one method that used for the community cause of death. But please, the other colleagues from other countries, please think about, with us, think about another alternative way to utilize the current medical information from the current health system, how to integrate, how to utilize that into the community cause of death work. And if we don't have enough information to a certainty cause of death, we have to use verbal autopsy. That is another alternative between MCCD and VA. That is what we are thinking. And Vietnam is trying to do to figure out that method, and we hope that other country will continue to think about that, so we don't feel lonely regarding to this work. Okay, yeah.
Thank you, Home. Yeah, and over to you.
Yeah, interesting that request at the very end where you don't want to feel lonely. I almost have a similar, but it's nothing to do with loneliness, but leadership. I would like to know whether there's anyone who knows of a country who linked their HDSS data, like there's a data flow system for HDSS VA data to the CRVS system, like it's contributing directly. What was that like? And I'm not talking of one site, like the entire, like if you have several sites in your country, how the whole of those sites were connected to the CRVS system. Thanks.
So yeah, something to think about. And if you are from a country where you've done that, maybe you can catch Jane during the coffee break and talk about that. So I think with that, we're at the end of our session. Another round of applause to all three of our excellent speakers. Thank you very much. And please continue the conversations over the coffee break or at the end of the day when we meet downstairs at the Garden Cafe. Thank you, everyone, for being such a wonderful audience, and have a good afternoon.